Hello everyone, my name is Chrystal Steyl. I'm an MSc student at Stellenbosch University, and today I would like to tell you a small bit about my project titled Host Genetic Factors Contributing to the Susceptibility to MIS-C. So during the COVID-19 pandemic, we saw the significant inter-individual variability in SARS-CoV-2 infected individuals, ranging from some individuals being asymptomatic carriers to others developing severe and in some cases lethal COVID-19. The majority of the individuals who developed severe or critical COVID-19 were of older age or had underlying comorbidities. However, in April of 2020, reports highlighted a new extreme phenotype in children, namely multisystem inflammatory syndrome in children, or MIS-C. So MIS-C, as I just mentioned, is a novel but rare and severe clinical syndrome in children and has been shown to be related to SARS-CoV-2 infection. It is rare as it only affects approximately every 1 in 3 to 4,000 children infected with the virus. And this is a strange phenotype because, as we all know, children infected with the virus are typically asymptomatic during the time of infection and do not require medical intervention. And although this is also true for the MIS-C patients during their time of infection, they go on to develop severe symptoms such as multi-organ dysfunction and systemic inflammation 4 to 6 weeks after their infection. So human genetic factors associated with the immune system has been proposed as a possible explanation for this extreme phenotype. And although many human genetic studies on COVID-19 and MIS-C has been conducted to date, the majority of these studies were conducted in Eurasian populations, with very limited data coming from Africa. And this is concerning because African populations are genetically very diverse, and therefore extrapolating the results from Eurasian populations might not be as accurate, and we might miss some human genetic markers. And this leads to the aim of my study, which is to identify novel human genetic markers associated with MIS-C in an African population. So for the methods, we are recruiting children admitted to Tygerberg Hospital and Red Cross Children's Hospital as a collaboration with UCT. These children had to meet the CDC and WHO criteria set for MIS-C. We are also recruiting some control groups, which include children who were infected with the virus but who did not develop MIS-C, as well as children who were diagnosed with something called Kawasaki disease, which is another hyperinflammatory syndrome that shows a lot of similarities to MIS-C. So the DNA is then extracted from the blood and then is sent to the South African Medical Research Council's Genomic Center, where they sequence the entire genome. I then receive the data and then do bioinformatic analysis using resources from the Center of High Performance Computing. And this includes things like quality control checks using FastQC, then aligning our data to a human genome reference called HG38, and then looking for any differences between our data and the reference. And these differences are called variants. We then prioritize the variants that are found to be rare in the population and that have been previously associated with immune system pathways. And then finally, we see which of these variants are likely disease-causing using tools such as EVI or Varsome Clinical. To date, we have been able to recruit 99 cases as well as 27 children who were infected with the virus but who did not develop MIS-C, and 12 children diagnosed with Kawasaki disease as controls. We have been able to whole genome sequence 48 of the MIS-C samples and 2 of the Kawasaki disease samples. And the bioinformatic analysis has been complete for all of these samples. So in the table, you can see 5 of our MIS-C case samples, and you can see that we start off with about 6 million variants per sample. After the prioritization of the variants, we have about 3,000 variants left over. And then when we look at the likely disease-causing variants in the immune system pathways, we find about 1 or 2 per patient. So now the question is, why is this study important? So this will be the first investigation between MIS-C and genetic susceptibility in an African population. It will also help us differentiate between the pathogenesis of COVID-19 in children versus adults. And further, since this study is conducted in African populations, we can identify novel variants associated with MIS-C. And this can lead to novel and improved therapeutic interventions in these at-risk children. And finally, add to precision medicine initiatives in the country, which can lead to cost saving in the future. Thank you very much, and I'd like to thank the following people, organizations, and funding bodies for making this project possible. Thank you.